who is attending to a neurological problem should ask themselves, and only by answering these three questions can you reach somewhere that can help you address what the problem is and find solutions to the problem. So it is very obvious as to what the first question is. The first question refers to whether there is an organic lesion or not. And the second question refers to the localization in the neuraxis. And the neuraxis in this patient can spread all the way from the cerebral cortex to the spinal cord. And finally, what is the lesion refers to the etiology. So is it a tumor? Is it a demyelinating lesion? Is it a tuberculoma? Or is it a stroke? Or is it hypoglycemia? The etiologies can be protean. There are so many etiologies that can lead to hemiparasis. But if you approach methodically, then you can reach somewhere. And we will examine these points one by one. I want to address the first question, is there a lesion, towards the latter half of the presentation. So we will start with the first question as to where is the lesion. Now to understand where is the lesion, that is the localization in neuraxis, you have to give importance and you have to be observant as to what the patient is telling you, and even by examination as to what is the pattern that this patient is trying to tell you, or what is the pattern that the examination is eliciting in terms of the weakness and in terms of the neurological deficit. So it is through this pattern that you can understand or pinpoint where the localization in the neuraxis is. So in our case vignette, the pattern is that the patient has hemiparesis. He did not have monoparesis, he did not have paraparesis. The patient has hemiparesis. So that is one pattern. And what kind of hemiparesis is it? It is a hemiparesis that involves the right upper limb and the right lower limb. So the side, there is a side to this pattern of weakness. And in that side, the weakness of the lower limb is more than the weakness of the upper limb. So there you know there's a differential weakness where the weakness of the lower limb is more than the upper limb. And it is also accompanied by facial weakness, probably on the right side. Also, patient complains of seizures and urinary incontinence. So what can we infer from this pattern is what I'm going to tell you in the subsequent slides. Similarly, the third question, what is the lesion referring to? Etiology of the lesion can only be elicited from the onset and progression. So coming back to our presentation of the case vignette, there are only two clues in this history that tells you the onset and progression, and that is the patient had a subacute onset. It was not a sudden onset, it was not an abrupt onset, it was not a acute onset, it was a subacute onset, and it progressed. This hemiparesis progressed over a period of 3 months. So this is the onset and progression of our case vignette. So in a patient who has come with hemiparesis, when we address the question, where is the lesion? The lesion for hemiparesis can extend all the way from cortex, through internal capsule, through the brainstem, midbrain, pons, and medulla, and up to the spinal cord. So how is it that we can determine where the lesion is? To understand this question better, you have to understand how the body is represented in the motor homunculus. That is the motor strip of the cerebrum. How is the body represented? The body is represented in an inverse way, where the head is facing the lateral surface of the cerebral convexity, and the arms are in the slightly above, still on the cerebral convexity, and the trunk and the leg would face, the proximal leg would be here, and the lower limb, the distal part of the lower leg would be on the medial aspect of the cerebral hemisphere. So the cerebral convexity contains the face, is represented by the face and the arm, the trunk, and the proximal lower limb, whereas the distal lower limb is on the inner side, that is the medial aspect of the hemisphere. Now from this motor strip, the corticospinal tract descends through the internal capsule, further descends into the midbrain, further onto the pons, and then onto the medulla, from where it crosses over, that is, it decussates, and then once it has crossed over, it descends on that side in the spinal cord to reach the arm or the limb or the trunk as to where the fibers are directed. So this is very important to understand, because a lesion here can cause hemiparesis, a lesion here can cause hemiparesis, a lesion here can cause hemiparesis, or a lesion here can cause hemiparesis. So how do we know that the lesion is in the cortex? To understand this, you have to refer back to the motor homunculus, and if the lesion is here on the cerebral convexity, then obviously the face and arm would be more involved than the leg, because leg is on the medial aspect or the inner aspect of the cerebral hemisphere. Similarly, because the cerebral convexity contains the speech centers, the Broca's area and the Wernicke's area. So if this convexity is what is involved, there will be involvement of the speech in the dominant hemisphere. And if the patient has thrown seizure, then it points to a cortical involvement, because seizures cannot arise from subcortical structures like internal capsule or medulla or midbrain. And of course, if there is a cortical sensory involvement like stereognosis or problems with two-point discrimination or graphesthesia, then you think of cortex as the possibility. Whereas if the patient has a leg involvement more than arm or face, then and a urinary incontinence, one tends to consider the possibility of a medial aspect of the cerebral hemisphere. That is because the leg is represented, the distal part of the leg is represented on the medial aspect of the cerebral hemisphere, and this medial aspect of the cerebral hemisphere also contains the bladder centers. So because of which, if the patient has urinary incontinence and has the involvement of leg more than the arm and face, one would think of the inner aspect or the medial aspect of the cerebral hemisphere. So some other cortical symptoms, the aphasia we have already referred to, apraxia, that is loss of motor programs. The patient says that he is not able to brush in the morning, even if there is no significant weakness on the dominant side. If the patient is not able to take the brush, apply paste over the brush, and then try brushing his teeth, if he is not able to do this motor activity, which is learned over and over again over many years, if he has lost this motor program, that's called apraxia, and this can be pointed to a cortical origin of the hemiparesis. Similarly, if the patient has forgotten how to recognize a familiar object, for example, if he's forgotten to recognize what a pen is, or if he's forgotten to recognize what a familiar person looks like, this is referred to an agnosia. This also can be pointed to a cortical origin of a hemiparesis. Similarly, if the patient has a visual field defect, like for example, the patient has a hemianopia, then again, this is pointed to a cortical origin of a hemiparesis. And if the patient has neglect of one side of the body, for example, if he is not able to shave, if he doesn't shave, and if he comes to the office or if he comes to the OPD partly shaven on one side of the face and the other half is not shaven, then you know this patient has a neglect. If he tends to wear the shirt's sleeves only on one side where the other shirt sleeve is hanging loose, then you know this patient has a neglect. If he neglects one side of the body, again, then you consider this is a pointer that this hemiparesis may be originating from the cortical site. Now moving on to the internal capsule. Now the internal capsule is different from the cortical side because in the cortex, the corticospinal tract is in the form of a corona radiata. It is spread out to encompass the entire cerebral convexity anteriorly and posteriorly and also medially and laterally. This kind of converges together into a densely packed internal capsule. So because it is densely packed, both fibers from the face, arm and leg are all kind of packed together, and because of which our patient will have a dense hemiplegia. So if the lesion is in the internal capsule, the patient will have a dense hemiplegia. By dense hemiplegia, we understand that the patient has equal weakness in the upper limb and the lower limb. There is no differential weakness, as like we saw in the cerebral cortex. The patient may also get a hemisensory loss in internal capsule lesions because the internal capsule is very closely present to the thalamus. So if the internal capsule lesion is causing some pressure effect or edema is compressing onto the thalamus, or if the thalamus is also involved because of the lesion, one may get a hemisensory loss. And similarly, because the part of the internal capsule also carries the visual fibers, and also the optic radiations can be closer to the internal capsules, so there can be homonymous hemianopias. When we move on to the brainstem, the peculiarity in the brainstem. By brainstem, we refer to the midbrain, the pons, and the medulla. The characteristic of a brainstem lesion that causes hemiparesis is that the cranial nerve is onto the side, palsy is onto the side of the lesion, and the hemiparesis happens on the opposite side of the lesion. For example, if the lesion is here, the midbrain contains the cranial nerves 3 and 4, and if the lesion is here, it may so happen that it will knock out the cranial nerve the third cranial nerve on this side, and it will also knock out the corticospinal tracts fibers that are traversing through this area. But because these corticospinal tract fibers are going to subserve the opposite side of the body, they come like this and they cross over and they subserve or they supply the opposite side of the body. The hemiparesis will be observed on the opposite side, whereas the cranial nerve third that is exiting the medulla will be palsied on the same side. So the brainstem lesion that is causing hemiparesis will have a crossed hemiplegia. By crossed hemiplegia, we refer to an ipsilateral cranial nerve palsy and a contralateral hemiparesis. And the reason is, why contralateral? Because the corticospinal tract has crossed over to supply the opposite area. If the lesion is here, the hemiparesis will be noted on the opposite side. Let's see a few examples of this. So this is the midbrain section where the corticospinal tract is traversing through the crus cerebri, and this is the third nerve nucleus, and from the third nerve nucleus one can see the third cranial nerve coming out like this. So if there is a lesion here, for example, a demyelinating lesion due to a multiple sclerosis, one will get a third nerve palsy on this side, and because the corticospinal tract is getting involved here, the hemiparesis will be on the opposite side, because at the level of medulla, this tract will cross over to the opposite side. And this here again is an example in the brainstem lesion in the pons. Now here you can see how the sixth nerve is coming down like this to the corticospinal tract. So this is the corticospinal tract. So if you have a lesion here, so the sixth nerve will be involved on this side, because the sixth nerve is coming out like this. But because the corticospinal tract is involved here, when it descends further into the medulla and crosses over to the opposite side, the effect will be seen on the opposite side. So here again, the sixth nerve palsy would be on this side, the hemiparesis would be on the opposite side. So again, to emphasize, a brainstem lesion causes a cross hemiparesis where there is an ipsilateral palsy and a contralateral corticospinal tract manifestation. The lesion is on the same side as the cranial nerve, but the manifestation is on the opposite side because the corticospinal tract crosses over at the level of medulla. So here again we can see at the level of medulla, this is the hypoglossal nerve or the nerve supplying the tongue. So here, if there's a lesion here, this is the pyramid. Before the pyramid, the corticospinal tract has crossed over. So here a lesion will cause tongue weakness on this side, and a little down this corticospinal tract would have crossed and the hemiparesis would be on the opposite side. Coming down further, when we reach the spinal cord, the clues to a spinal cord lesion is that the face or the cranial nerve is spared. And it is very common to see a facial involvement in hemiparesis, but if there is a sparing of a facial weakness, then there is a likelihood that this hemiparesis is originating in the spinal cord. The cranial nerves are not affected, obviously, because the spinal cord is below the foramen magnum. So anything below the medulla, the cranial nerves are less likely to be involved. There is an exception to this, but for you guys, you may not remember, but the exception is That fifth nerve may still be involved in the spinal cord, and there will be a hemisensory loss, which doesn't involve the face. So this is the lesion of the spinal cord. You see how the lesion is eccentric to one side. So this particular lesion will not involve the face, it will not involve the cranial nerves, and it may cause the hemisensory loss in addition to a hemiparesis. Here the hemiparesis will be on the same side as the lesion, because this lesion is in the spinal cord is below the level of decussation. So decussation happens higher at the level of medulla, but if the lesion is at the level of spinal cord, it is below the level of decussation, and hence the hemiparesis will be on the same side as the lesion. So having discussed the various patterns that leads to different localization, now we will answer the third question as to what is the lesion. And this obviously refers to what the etiology is. Etiology can range from being vascular to electrical abnormalities to a demyelinating condition to a space-occupying lesion like a tumor. So how does one know what is what? Just as we saw earlier, it is the onset and progression that tells you about as to what the lesion is or as to what the etiology is. So the clues to a vascular lesion. Now the vascular lesion can be a ischemic stroke, and it can be a hemorrhagic stroke. It can be cortical venous sinus thrombosis, or it can be a bleed into the tumor. So these are the various, or it can be a vasculitis. So these are the various possibilities among a vascular etiology. All these etiologies are characterized by an abrupt onset or a sudden onset, or like a bolt from the blue. Typically, the patient would tell you that he was having a cup of tea and reading a newspaper, and suddenly the newspaper fell off his hand, or the cup of tea fell off his hand, and then he fell down from his chair, and when he tried to get up, he could not, and he had to call out or cry out for help to be taken to the bed or taken to the ambulance or taken to the car on the way to the hospital. The patient will remember the suddenness, the abruptness. If the patient is not able to remember, then the aspect of suddenness is a kind of a little muddle, and you cannot be sure. But if the patient is telling you pinpointedly that I was shaving in the morning when this happened, or I was straining in the toilet when it happened, so this is a pinpoint time in his daily routine, and that kind of refers to or points to a suddenness. So if there is a suddenness, abruptness, like a bolt from the blue, then this is likely to be vascular. And I told you what the vascular etiologies could be. It could be an ischemic stroke, like a thrombus going from the heart. It could be a thrombus because of atherosclerosis. It could be a thrombus superimposed on an inflammation of the vessel, like a tubercular vasculitis, or it could be a vasculitis due to a systemic lupus erythematosus.
Is there any lesion growing?
Or it could be a cerebral venous sinus thrombosis, which is a thrombus forming in the dural venous sinuses, commonly seen amongst alcoholics, commonly seen people who are posted or trekking high altitude. Another aspect of a vascular etiology is that it is usually maximum at onset. So an embolic stroke would be maximum at onset. The patient would wake up with the maximum deficit or grade 1 power, grade 0 power. And then as the days progress or as the months progress, he will slowly recover from it. Rarely in vascular events, they may worsen over the next 48 to 72 hours. This happens because of the edema that surrounds the lesion. And after 3-4 days, the edema starts to settle down and the patient starts improving. So in a nutshell, the deficit is maximum at onset. It may worsen for 2 to 3 days, but thereafter, it is going to be a gradual recovery from there on that may last a few months. And this is an MRI of a middle cerebral artery stroke, and you can see how the cerebral convexity has been knocked out by this stroke. And because it is the cerebral convexity and not the medial aspect of the cerebral hemisphere, this patient is likely to have weakness of the face, weakness of the arm and the trunk, and less weakness of the legs. So this is called a faciobrachial weakness, and it is quite characteristic of an MCA stroke. As against that, this is an ACA stroke, which is affecting the anterior cerebral artery. The previous one, MCA, referred to the middle cerebral artery, and this is the inner aspect of the cerebral hemisphere where the ACA supplies, and this will manifest in the, if you refer back to the motor homunculus, this will manifest in leg weakness more than the arm weakness, and because this is also the area where the bladder centers are present, the patient may also have incontinence of urine. Coming further down, among the vascular etiologies, this can be a vertebral artery dissection. For example, a cricketer died because the ball had hit his vertebral artery recently. And if there is a trauma, or even if it is a spontaneous vertebral artery dissection high in the cervical cord, you may get hemiparesis, where the weakness will be on the same side as the lesion, and there may be a contralateral loss of temperature and pain. On the same side, there will be loss of sensation in the posterior column. This is referred to as a bronze accord, and this can happen in the spinal cord. And vertebral artery dissection is a very possible cause. In a more Indian setting, this happens in patients who undergo a neck massage following a haircut, where the barber tries to kind of twist the neck for some clicking sounds, and this can cause a vertebral artery dissection. And I have treated a few patients, and every neurologist in our country has seen at least one patient of vertebral artery dissection presenting like this because of the barber. The next kind of etiology could be of electrical, where the hemiparesis arises out of seizures or migraine. So here again, like in the case of a seizure, this happens due to a Todd's paresis, where there is a seizure activity followed by hemiparesis. The seizure is often missed or happens during sleep. When the patient wakes up, he realizes that one side is not moving. So here again, an electrical activity is also sudden. But because this is electrical activity, there may be a positive phenomena in the form of a twitching or a tonic-clonic seizure. In case of migraine, there may be a marching deficit, in the sense that the deficit may start on the face, then it may progress to the hand or the arms, and then to the legs. So this kind of a marching neurological deficit that happens over a few seconds is a clue to a migraine. Whereas a sudden abrupt onset positive phenomena, tonic-clonic jerks, is likely to be a seizure if the history is available. Sometimes the history is not available, so the suddenness must keep you. But what will differentiate this from a stroke? The differentiation comes from if the patient has a history of a seizure or a migraine. If the patient is already on treatment for migraine or is already on treatment for seizures, then the likelihood of this being a Todd's paralysis or a hemiplegic migraine are that much more. And then again, very different from a vascular stroke is the recovery of these patients, which happens in a matter of hours or days. The Todd's paresis doesn't extend beyond a few days at the most. And similarly, hemiplegic migraine recurs in a few days' time. This is very different from a stroke or hemiparesis due to a vascular etiology, where the recovery happens gradually over periods of weeks to months, typically 4 to 5 months. It may last up to a year as well. Moving on to the next pattern of the next etiology of demyelination. A demyelinating lesion, for example, a multiple sclerosis or a acute disseminated encephalomyelitis lesion, is likely to be acute subacute. They are almost never sudden. So acute or a subacute lesion should point to a demyelinating lesion. And unlike a vascular etiology that we saw earlier, or an electrical etiology that we saw earlier, a demyelinating lesion typically progresses over a few days to weeks, in the sense that if the patient says that I developed facial weakness over the past 2-3 days, and then as the days progress, he comes back to the OPD and says that now I have a weakness over my right upper limb as well, not able to break chapatis, not able to wear shirt. And then 2 weeks later, he says that my chappals are slipping off, and I'm not able to grip my chappals. I'm not able to climb my stairs. I'm not able to get up from a squatting position. So here is a typical progression over days to weeks. So this is again different from the vascular etiology, where we saw that the maximum deficit happens in the beginning or maximum in the first 2-3 days. Unlike that, here the neurological deficit is worsening over days to weeks, and after it worsens, it kind of attains a plateau. For example, after he's reached the weakness of his hands, he may say that it did not progress any further, and he may remain in that phase of plateaued weakness of face and arm for weeks, and then over the next few weeks there may be a phase of recovery. So this is a typical pattern of a demyelination, where the disease progresses over days to weeks, plateaus, remains static for a period of few weeks, and then starts gradually recovering from that neurological deficit over a period of few weeks, and may completely recover or may remain partly paralyzed on the side, depending on how extent and what is the severity of demyelination. And another important aspect of demyelination, and a very important clue, is the presence of demyelinating neurological deficits. So this pattern of weakness of any neurological deficit, if it happens with remissions and relapses. So if there is a history that 3 years ago the patient had a similar kind of weakness on the left side, then you know that this is likely to be a demyelinating lesion, because there is a history of remission and relapses. And finally, coming to a space occupying lesion, unlike the vascular, electrical, or a demyelinating lesion, a space occupying lesion the onset would be subacute to chronic. So here the symptoms would happen over weeks to months to maybe years. And the symptoms they don't plateau, they don't recover, they continue to progress. They are relentlessly progressive. And this may also be associated with headache and projectile vomiting. So this here what you can see is a parafalcine meningioma, which is a midline kind of tumor pushing the hemisphere to one side. And this is on the inner aspect of the medial aspect of the cerebral hemisphere. So here again, we referred to the questions of where is the lesion, and we deliberated on what is the lesion. But the first question went unanswered as to is there a lesion, and as psychiatric residents, you would be interested in this question more than I am. But as a neurologist, I would address the last two questions first. Try to localize the lesion and try to find an etiology, and use all my resources to pinpoint the lesion and determine an etiology. And when I don't find one, only then I start thinking of the first question as to where is there a lesion. And some of the clues that you may obtain as to the non-organicity of a lesion comes from the examination. So when you examine patients with non-organicity, and typically you would examine a patient with hemiparesis lying on the bed, and you raise the person's, and typically these patients are young women. And when you raise the paralyzed sides, for example, you raise the right upper limb and you leave it in the air. Naturally, because the limb is weak, it will fall. But when it falls in such a way as to avoid injury to the patient. It will avoid injury to her face and to her eyes. So typically when I would examine patients and when I suspect non-organicity, I would raise the arm and take it over her face or over his face and then just drop it. And also be careful not to, I'll guard her eyes maybe with the other hand, but I'll be careful not to injure the patient. And if the patient is consistently avoiding injuries to self, then that is a pointer to a non-organicity. Also, if the patient is in a state where he or she can walk, and when you make the patient walk, you will find that the patient falls in such a way as to avoid injuries to self. And sometimes when they walk, the kind of gait also gives away the nonorganicity, because the hemiparetic gait is a very characteristic gait where the person tries to circumduct his lower limb and clear the ground. And this is not the gait that you tend to see in nonorganicity. There may be very bizarre gaits bordering on aesthesia, abasia. So this could again be a clue to a nonorganicity. Similarly, when you examine the patient for power, suppose the patient is partially paralyzed and you are trying to elicit the motor power. And when you assess the patient in lying down position and you find that you ask the patient to flex his hip, and when the patient is flexing his hip, he is able to do it very minimally, in the sense that he is not, there's barely a flicker, or he's just barely able to raise the leg from the bed. And the same patient, when you ask him to get down and stand with support, if he's able to stand. So this is a discrepancy, a major discrepancy, because any patient will require at least grade 3 power to stand, which means that in a lying down position, the patient should be able to lift the limb against gravity without difficulty. The patient may not be able to withstand the resistance, but the patient will definitely be able to raise the limb from a lying down position. This discrepancy, this is just one of the examples of discrepancy, but there may be other discrepancies. And when you have such variable examination findings, that also between standing, sitting, lying, or in between two examinations that are only just minutes apart or hours apart, then you again start suspecting nonorganicity. And Hoover's sign, I'm sure being psychiatric residents, you are all aware of what Hoover's sign is, where you keep both hands under the feet and you ask the patient to raise one leg. And in a normal patient, you should feel the pressure of the other foot pressing on your hand. So if this counter pressure on the other side is not there, then the effort of the patient is not there, and that's a positive we were saying, and this could sometimes give a clue to nonorganicity. And finally, one should always err on the side of caution, and even when you suspect that there is nonorganicity, and even if there is the slightest doubt as to the presence of organicity, one must do an MRI. And if the MRI is normal, then again that is a clue to a possible non-organicity. But mind you, a normal MRI can be there in many conditions with organic conditions causing hemiparesis. Some of the examples would be a seizure. A TOTS paresis MRI may be absolutely normal. And similarly, hemiplegic migraine, the MRI may be absolutely normal. So a normal MRI does not rule out organicity. However, in the setting of the patient, after your examination, if the suspicion is high, a normal MRI would kind of help you rule out organicity. So we come back to a case minute, and let's see what our patient has. So our patient is 55-year-old male. The second question that we want to answer will be answering through the pattern of weakness. And here the pattern that we see is that of a hemiparesis, a right upper limb weakness and right lower limb weakness, with weakness of the lower limb more than the upper limb, and there is a facial weakness on the same side. Patient also has seizures and urinary incontinence. So what can we infer from this? The patient has a right hemiparesis. So this means that the lesion has to be in the left side if it is in the brain, and if it is in the spinal cord, the lesion has to be on the right side. So because the patient has a facial weakness, we know that this cannot be in the spinal cord. So our patient has a right-sided facial weakness with right-sided hemiparesis. So this is likely to be a left-sided brain pathology. Now this is a right-sided facial weakness. My bad, I didn't mention the right here. So this is a right-sided facial weakness. So we know that this is not a cross hemiparesis, because the cranial nerve palsy is on the same side as the hemiparesis or the limb weakness. So because they're on the same side, this is not a cross hemiparesis, and hence all the brainstem localizations are ruled out. So our lesion has to be above the brainstem. So above the brainstem, the possibilities were between an internal capsule lesion or a cortical lesion. Now, because we know that an internal capsule is a densely packed area, and in that densely packed area, it leads to a dense hemiparesis, which further means that the weakness is equal in the upper and the lower limb, which is not so in our case period. The right lower limb is more weak than the right upper limb. So this is unlikely to be in the internal capsule, and our lesion goes even higher up to above the internal capsule to the cortical region. So from this, just the pattern of the weakness, we could ascertain that this could be a cortical lesion on the left side. So once we have reached that kind of localization, we also look for supporting features, and there we see that the patient has seizures. So we know that this patient has seizures. So seizures, we had discussed earlier, cannot arise from subcortical structures. It cannot arise from the corona radiata. It cannot arise from internal capsule. It cannot arise from the brainstem. So just by this one word in the history that the patient had seizures, we are more confident of placing the lesion in the cortex. So not only is a lesion in the left hemisphere above the internal capsule, the lesion is somewhere in the cortex or at least involving the cortex. And because a patient also has a urinary incontinence, we know that the bladder centers are in the medial hemisphere or on the medial aspect of the hemisphere. We know that this is a lesion involving the medial aspect of the hemisphere. So not only is a lesion in the left hemisphere above the internal capsule, it is a cortical lesion or at least a lesion that involves cortex, and also it's a lesion that is in the medial aspect of the left hemisphere, and this medial aspect is also kind of, the clue is given by the fact that the weakness in the lower limb is more than the weakness in the upper limb. And that clue comes from the representation of the motor homunculus, where the lower limb distal aspects are on the medial side of the hemisphere. So we have localized the lesion. We have answered the second question as to where the lesion is. And now answering the third question as to what the lesion is, the etiology, and that will come from the onset and progression. So here the onset is a subacute onset, and the course is progressive. So with this onset and progression, the vascular etiology is ruled out, because this is not a sudden onset, an abrupt onset, bolt from the blue. Also, this patient is not progressing, plateauing, and then recovering. So this patient is continuing to progress over a period of 3 months. So this is likely to be a space occupying lesion. So these are the characteristics. A subacute chronic lesion, it is progressive, and the lower limbs are more involved than the upper arm and face. There is seizure and there is incontinence. So this makes a lesion a space occupying lesion in the cortex, involving the cortex and involving the medial hemisphere. And this case vignette is a real patient, and this patient had a parafalcine meningioma, the MRI of which I had shown you earlier 2 slides ago. So what are the stroke mimics? There are many conditions that can mimic a stroke, and one should know them, because a patient may come to you with a sudden or acute onset of hemiparesis, and though the first differential will always remain a vascular etiology, we should rule out what are some of the stroke mimics. And principally among the stroke mimics are the metabolic derangements, the post-ictal weakness, which is the Todd's paresis, migraine, we discussed about them, some bleeds due to trauma, and could be an hypertensive encephalopathy. So an acute onset hemiparesis, you should have this checklist. Other than stroke, it could be a cerebral venous sinus thrombosis, It could be a Todd's paresis. It could be an acute disseminated encephalomyelitis. The typical history, this is a demyelinating condition, and the typical history here is that there is a history of vaccination, like a COVID vaccination or some other vaccination, or rabies vaccination, and then or a fever, and the patient lands up with hemiparesis in a gap of a week, 10 days or 2 weeks. If the patient has hemiparesis with fever, consider possibilities of herpes simplex encephalitis and CNS tuberculosis. Remember, tuberculosis can cause vasculitis, and this vasculitis can cause a stroke-like picture. So these CNS tuberculosis is a possibility in an acute stroke-like process, especially when there are constitutional symptoms, fever, weight loss, cough, lymph nodes, and other things. Always remember, hypoglycemia is a stroke mimic, and I've treated innumerable hypoglycemic patients who have presented to emergency as stroke. Before we thrombolize a stroke, it is a protocol to check blood sugars, and if the blood sugars are 40, 50, 60, you have to give 25% or 50% dextrose, 50 ml, and make sure and observe for reversal. And the characteristic of hypoglycemic hemiparesis is that if the duration has been short, then it will rapidly reverse over a matter of few minutes to few minutes. Similarly, hyponatremia. This can mimic a stroke where they may present with hemiparesis, and this commonly occurs when the patient has had a stroke in the past. He is recovered from it, and he is almost near normal. He's going about his normal activities, and because of some diuretic or because of repeated vomitings or because of some etiology, drug could be a possibility that he goes into hyponatremia. And this hyponatremia can uncover a compensated hemiparesis because he had a stroke in the past, which was compensated over a period of time. A metabolic insult like a hypoglycemia or hyponatremia can uncover that compensated insult and manifest in stroke. So once you correct the underlying metabolic etiology, these patients, they rapidly recover. How do we investigate these patients? An MRI of the brain or the cervical spinal cord, depending on where you have localized the lesion, should be your first investigation. If a vascular etiology is suspected, and you can only suspect a vascular etiology from the onset and progression. Once again, vascular etiology is sudden, abrupt, like a bolt from the blue, and if that is the presentation, then you should also ask for an angiography. You should screen that patient for vascular risk factors if a vascular etiology is suspected. And these vascular risk factors, all of you know, are diabetes, smoking, tobacco consumption, binge alcohol drinking, dyslipidemia, sedentary lifestyle. So there's so many of them. We should screen for them. Also, if during examination, you should auscultate the neck for a possible carotid bruit, because a carotid stenosis can also be a vascular risk factor leading to a stroke. And while you're auscultating the neck, you can make an attempt to auscultate the precordium, and if you find some gross murmur or if you find irregular pulse, then this is also a possibility that this patient is having a vascular risk factor like an atrial fibrillation or a valvular heart disease, from where a cardioembolic stroke may arise. Secondly, the other three investigations, namely the EEG, vasculitis, workup, and infection. So EEG is only done when you suspect a seizure or a Todd's paresis. So if there is a history of seizure and you think that this could be Todd's paresis, in that setting you may want to do an EEG, and EEG may pick up an interictal spike and wave pattern, or a focal onset. Mostly a Todd's paresis results from a focal onset seizure, and many of them turn out to have a structural lesion in the brain. A vasculitic workup or infectious workup is indicated when there is a constitutional symptom. The patient has features of weight loss, the patient has features of arthritis, joint swellings, oral ulcers, genital ulcers, the patient has fever, the patient has lymph nodes, patient has rashes. Now you have conditions like this, you will order a vasculitic workup that involves the doing an ANA screen. At least ask for anti-nuclear antibody, ANA, well screen, and similarly, not to forget, the possibility of a HSV encephalitis, a treatable condition. So you should work up for it. HSV, PCR, and also probably do a MOM2, which is skin test, and do a chest X-ray. If there's lymph node, biopsy the lymph node, do an FNS. And with that, I conclude. So just to summarize, hemiparesis, the conditions are many that can lead to it. If you approach systematically, you will reach a localization, and only when you reach a localization can you start thinking of a possible etiology. And etiology again will depend on the onset and progression what we discussed. So when you get a case in the exam, if you follow these logical steps, you will, I'm sure, reach not only the localization but also the etiology. Thank you.
Thank you, Professor Wilson, for bringing out in such a lucid manner and in fact rather clarifying everything which would have created confusion for many people. So if there are any queries, they can unmute themselves and ask, or put in the chat box, please. Anybody, if they have any query, if they would like to ask something, we don't get MD Neuro often, and sir is quite a neurophysician of eminence and brought it out in very lucid manner. Any query? If there are none, thank you, Professor Wilson. I think it was quite brought out in a well manner for people to understand, and I think many of them won't have gone through the neurology part to actually ask few questions. But we will keep on conducting such sessions, and later we will be ready for